This is a video in clinical medicine from the New England Journal of Medicine.
Hip pain is reported frequently by patients of all ages. Although hip pain is common, the hip joint is complex, which can make it difficult to obtain a relevant patient history and perform a proper physical examination. This video describes the anatomy of the hip and demonstrates how to assess a patient who presents with hip pain. The first step in the assessment of a patient with hip pain is to obtain a focused history. Ask the patient to describe when the pain began, what alleviates the pain, whether certain movements, such as climbing stairs or standing from a seated position, aggravate the symptoms, what makes it worse, whether the pain radiates, and the characteristics of the pain. Ask the patient to rate the severity of the pain on a scale of 1 to 10. Also ask whether the patient has had a specific injury or trauma, or whether the pain has become chronic over time. Finally, ask whether anything relieves the pain, such as medications, exercise, or rest. An accurate, comprehensive history should consider all the potential sources of hip pain. It is important to determine the location of the pain, and then to attempt to reproduce the pain during the physical examination. Be aware that hip pain may be caused by conditions affecting the back, and be aware that lower back pain may be caused by conditions affecting the hip. Be sure to perform pulse palpation and auscultation to check for peripheral artery disease, which may cause pain at the hip. A full sensory examination and assessment of deep tendon reflexes may also be indicated if you suspect neurologic impairment. Hip pain can often be classified based on the location of pain the patient describes. For example, back pain, lateral hip pain, medial hip pain, and posterior hip pain. Hip pain can also derive from areas outside the hip, such as an inguinal hernia or a lumbar spine condition. Refer to the print supplement to this video for a more comprehensive list of the differential diagnosis of hip pain. A general hip examination includes gait analysis, visual inspection, palpation, assessment of range of motion, and the performance of various maneuvers and diagnostic tests. Assess both the affected hip and the unaffected hip for the purpose of comparison. Generally, if a patient presents with bilateral hip pain, one hip is more symptomatic than the other, and comparison is still warranted. Perform the examination with the patient first in the standing position and then in the supine contralateral decubitus in prone positions. To facilitate proper visualization, ask the patient to bring or wear shorts to the appointment or to put on a gown. To ensure the safety of patients with a high risk of injury, try to minimize their position changes after you have completed the examination. Begin the examination by observing the patient's gait. Instruct the patient to walk back and forth from one side of the room to the other. Look for signs of discomfort, asymmetry, or an otherwise atypical gait. There are 4 common gait abnormalities that result from hip disorders. The first is called a coxalgic gait, meaning that the patient's trunk leans to the affected side because doing so decreases joint forces and lessens pain. Coxalgic pain is most common in patients with osteoarthritis and osteonecrosis. The second gait abnormality is termed antalgic gait. Persons with an antalgic gait spend less time bearing weight on the affected extremity in order to decrease the amount of time that force is transferred through the affected limb and to avoid pain. An antalgic gait can be caused by a variety of conditions that can affect the limb anywhere from the hip to the feet. These include osteoarthritis, infection, and soft tissue injury. The third gait abnormality is termed Trendelenburg gait and is caused by weak hip abductors. Patients with a Trendelenburg gait drop or tilt the pelvis contralateral to the side of the pain. In addition, the trunk may lean to the affected side to regain balance and avoid falling. This gait is common in patients with hip dysplasia, femoral neck fracture malunion, osteonecrosis with collapse, and any condition that shortens the hip abductor muscle lever arm. A fourth gait abnormality is termed neurologic or asymmetric gait, which results in a shorter stride length in the affected leg. Typically, this gait is caused by a flexion contracture or decreased internal rotation on one side of the body. Perform a visual inspection of the patient from the front, from each side, and from the back, noting scoliosis, misalignment, muscle wasting, arch abnormalities, signs of inflammation, and scars. Patients with muscle imbalances or postural insufficiency may present with the pelvis tilted in an anterior-posterior direction or on a lateral axis. Hip tilt is often associated with lower back pain. Skin inflammation and redness may indicate an infection such as cellulitis. Scars may be a sign of previous surgery or trauma. Muscle atrophy may represent neurologic impairment or injury. Palpate the anatomical structures of the hip. Palpation can help to identify specific areas of injury and narrow the differential diagnosis. With the patient in the supine position, begin by placing your hand on the lateral aspect of each hip joint to assess for warmth and tenderness. A warm joint may indicate infection or acute injury. Palpate the greater trochanter. Pain may indicate bursitis, an inflammation of the trochanteric bursa. The iliotibial band overlies the greater trochanter and can also be a source of irritation and inflammation. Palpate the anterior superior iliac spine and the anterior inferior iliac spine. Pain at either of these sites may suggest an avulsion of muscular attachments that has led to fracture or acute muscle strain. Palpate the ischial tuberosity. Pain could indicate a hamstring injury or tendinopathy. Palpate the inguinal ligament. Pain here may represent iliopsoas injury or an inguinal hernia. Palpate the iliac crest. Tenderness in this area could result from an oblique avulsion fracture. In children, however, tenderness here is common because the growth plates are active. After completing this series of palpations, measure the length of both legs from the anterior superior iliac spine to the tip of the medial malleolus to determine whether there is a discrepancy in length, which could be caused by congenital malformation, previous insult to the growth plate, trauma, or environmental causes. Next, examine the active range of motion in each hip. Assess flexion, extension, external rotation, internal rotation, adduction, and abduction. If the patient does not have a full range of motion, provide assistance. Severe pain with assessment of range of motion may suggest a native septic hip joint or severe osteoarthritis. Excessive or obligate external rotation in a shortened leg may suggest a hip fracture or hip dislocation, and is most commonly seen in elderly patients. The detection of popping or clicking in the joint may indicate a labral tear, whereas the detection of popping or snapping outside the joint over the greater trochanter may indicate iliotibial band syndrome. These symptoms should be replicated if possible to confirm a diagnosis of iliotibial band syndrome. Note any sensation of grinding or crepitus in the patient's joint as you passively move it through its range of motion. Losses in active and passive ranges of motion are commonly associated with femoral acetabular impingement or osteoarthritis. Pain during flexion, adduction, or internal rotation of the hip may represent femoral acetabular impingement, whereas osteoarthritis is associated with grinding and crepitus when the joint is moved. Femoral acetabular impingement is the result of excess bone growth along the anterolateral aspect of the femoral head or the lateral lip of the acetabulum. This excess growth restricts the range of motion and may cause pain when the bones of the hip joint come in contact with and pinch tissues such as the labrum. Specifically, a patient with early signs of hip arthritis will have limited or painful hip abduction and rotation. Patients with osteonecrosis of the hip and patients with osteoarthritis may have similar presentations, with locking, popping, or painful catching or clicking during an assessment of range of motion. A thorough patient history can help to distinguish osteonecrosis from osteoarthritis, since glucocorticoid use and chronic alcohol use are risk factors for osteonecrosis. After performing active and passive range of motion, apply resistance while the patient actively performs each range of motion. This maneuver will test for symmetry or pain. Painful movement against resistance may indicate a muscle strain, tendinitis, or osteoarthritis. Several tests are often used to determine the source of a patient's pain or discomfort. These include the Stinchfield test, the log roll test, the Fader, or flexion, adduction, and internal rotation test, the Faber, or flexion, abduction, and external rotation test, Ober's test, and the Thomas test. The Stinchfield resisted hip flexion test helps to identify intra-articular hip disorders. Ask the patient to lie in a supine position and to elevate the leg while flexing slightly at the hip and keeping the leg extended. Once the patient has elevated the leg to an angle of 30 to 45 degrees, apply resistance to prevent further elevation. If this maneuver elicits pain, the patient probably has an intra-articular disorder, such as osteoarthritis or femoral acetabular impingement. In addition, a positive Stinchfield test may indicate other conditions such as sciatica, athletic pubalgia, or iliopsoas tendinitis. Be sure to assess each leg. The log roll test is frequently used in cases of trauma to detect injuries such as femoral neck fractures, hip dislocations, and native septic hip joints. The log roll test is used to assess patients for a labral tear, ligamentous instability, or capsular laxity. With the patient in the supine position, passively move the patient's leg through maximal internal and external rotation. If you feel clicking or popping, then an acetabular labral tear may be present. An increased range of motion on one side and the normal range of motion on the other side indicates ligamentous or capsular laxity. However, bilateral laxity can be present in healthy patients. The Fader test helps to determine whether there is hip impingement or a labral tear. With the patient in the supine position and with the knee fully flexed, passively flex the patient's hip to 90 degrees while simultaneously adducting and internally rotating the thigh. If the patient reports hip or groin pain during this maneuver, there may be a labral tear. The Faber test, also known as Patrick's test, is used to detect intra-articular lesions, iliopsoas strain or bursitis, or sacroiliac disease. With the patient in the supine position, passively flex the patient's hip to an angle of 90 degrees while simultaneously abducting and externally rotating the hip. If hip or back pain occurs or the range of motion is limited, the patient may have intra-articular hip lesions, iliopsoas strain or bursitis, or sacroiliac disease. Patients with sacroiliac disease may also present with lower back pain. Ober's test is used to determine whether the patient has a tight iliotibial band and tensor fascia lata muscle. With the patient lying on the unaffected side and the hip in slight extension, passively abduct the patient's leg and allow it to drop into adduction. If the leg remains in abduction or cannot be fully adducted, there is reason to suspect that the patient has a tight iliotibial band or tensor fascia lata muscle. The Thomas test is used to determine whether there is tightness in the hip flexors. With the patient in the supine position, ask the patient to fully flex one hip. Observe the contralateral side. If the contralateral hip flexes and the leg lifts off the table, the patient most likely has a fixed flexion deformity. A fixed flexion deformity may represent contracture of the hip or a tight iliopsoas muscle, either of which will prevent extension of the hip. Common pitfalls of hip examination include incomplete visualization, incomplete assessment of the range of motion, difficulty with palpation of anatomical landmarks in patients with a high body mass index, and evaluation of only one limb. Evaluation of both limbs is essential to accurate diagnosis. After a comprehensive history and physical examination, imaging may be necessary. When a patient presents with hip pain, an anterior-posterior plain film, as well as a lateral view of the pelvis, may be obtained. If a labral tear is suspected, a magnetic resonance arthrography is typically warranted. If there are unexplained physical findings or risk factors for hip emergencies, such as osteonecrosis of the femoral head, an MRI should be obtained. An assessment of hip pain involves taking a comprehensive patient history and performing a physical examination. This video is meant to help healthcare providers diagnose disorders of the hip. Arrange for imaging in consultation with a hip or sports specialist if necessary. An understanding of the anatomy of the hip is essential in performing a comprehensive physical examination. The hip consists of two bones, the femur and the acetabulum. The major anatomical landmarks of the femur are the femoral head, the femoral neck, the greater trochanter, and the lesser trochanter. The primary area of articulation in the hip joint is between the femoral head and the pelvic acetabulum. The acetabular labrum is a fibrocartilaginous structure that lines the outer rim of the acetabulum. It effectively deepens the socket and serves as a suction seal, thereby contributing to the overall stability of the joint. The femoral head is covered by articular cartilage that allows the joint to glide smoothly against the articular surface of the acetabulum. The hip joint is enclosed by a fibrous capsule that attaches to the periphery of the acetabulum and anteriorly to the base of the femoral neck. The tensor fasciae lati originates in the anterolateral iliac crest. The muscle is confluent with the iliotibial band, which originates at the tendons of the tensor fasciae lati and gluteus maximus, runs along the lateral thigh, and inserts distally at Gerdy's tubercle, located on the lateral aspect of the proximal tibia. This dense tendinous band stabilizes both the hip and the knee joint. Laterally, the gluteus maximus inserts on the iliotibial band and gluteal tuberosity of the femur. The gluteus maximus is responsible for extending the hip and laterally rotating the hip. The gluteus medius and minimus insert on the greater trochanter of the hip, abduct the leg, and are a common source of lateral hip pain. Posteriorly, the major muscles of the hip include the gluteus maximus, gluteus medius, gluteus minimus, and piriformis, as well as the short external rotators. The hamstrings, which include the semimembranosus, semitendinosus, and biceps femoris, are essential for hip extension and knee flexion. Other relevant muscles include the iliopsoas, sartorius, and rectus femoris. Adductors of the leg include the adductor magnus, adductor brevis, adductor longus, and gracilis. Three major nerves lie proximate to the hip: the femoral nerve, the obturator nerve, and the sciatic nerve. The femoral nerve can be damaged through direct trauma or prolonged pressure to the anterior aspect of the hip, which may cause weakness, numbness, tingling, or pain along the anterior thigh and leg. The obturator nerve can be irritated by hip inflammation, which may result in and cause medial thigh and knee pain. Compression of the sciatic nerve causes sciatica, a shooting pain that runs down the back of the gluteal region and the leg. The three major arteries close to the hip are the femoral artery and two of its branches, the medial and lateral circumflex arteries. Disruption of the medial circumflex artery can cause osteonecrosis of the femoral head.